Hello everyone and welcome to a new episode of CCLG's Research Talks for Parents and Public. And you might have noticed it looks a little different tonight. It's because it's our first webinar with our new brand and new name. So we are now CCLG, the Children and Young People's Cancer Association. So I'm Ellie Ellicott and my job is sharing research with our supporters. So let's start with some quick housekeeping for everyone. We'll be holding a Q&A session at the end of the talk, so please do submit your questions whenever you think of any using the Q&A button that should be at the bottom of your screen. If you'd like to use the chat function, please make sure you set the to drop down to everyone or people may not see your message. The webinar is being recorded and will be available publicly on our YouTube channel. I'll send out the link when it's ready to watch. So, this month's talk is called Is Childhood Cancer Inherited? And is being led by Dr Mette Jorgensen. Mette has worked as a consultant paediatric oncologist at Great Ormond Street Hospital for 10 years, having trained at Gosh and University College London. She has a special interest in children with brain tumours, rare cancers and cancer predisposition syndromes, which are inherited conditions that make a child more likely to develop cancer. So, without further ado, I'm going to hand over to Mette. You're on mute. Sorry.
Wait, after 5 years, still haven't quite learned. Right, let me share my screen. Okay, that's because the dog was barking in the background, so I can only apologize for that. So, yeah, so thank you very much for this opportunity, and I guess we'll take questions at the end, so that's fine. So I'm going to talk about whether childhood cancer is inherited and a bit about cancer predisposition syndrome. I run a clinic at Great Ormond Street, and I will just mention that briefly. But yeah, I'm happy to take any questions, and my details are there. So let me just see if I can... Fine. So, so these were some of the titles we were thinking about, and hopefully this is what I will answer for you. What are family cancers, predisposition syndromes, what are they? Can it be passed through families, and is it inherited? And I think some of those might be of importance for you. So it really goes back to 1990. It took about 10, 11 years to sequence the whole human genome, and it was published in early 2000. And that really was the foundation for what we understand about cancer genetics, but also obviously the whole human genome. We can now do this as an afternoon or even much quicker, but back then it took over 10 years to get to do this. And what we were hoping with that was really that we could then sequence, or what happened was that we sequenced all types of cancers. So like the German team got a lot of brain tumors and have excelled in that. The Sanger Institute got breast cancer and bone cancer. So different centers got different cancer types to try to sequence it. And the message there was, or the importance of that was that you could compare what the genomics on the DNA looked like in the tumor cells compared to the kind of whole body structure, and I'll come back to that, but all of our kind of normal DNA build, and therefore decide what made the tumor difference, and trying to understand if we could then maybe target some of those differences. And there was this promise around 2000, between 2011 and 2020, I guess there was this promise that we would have targeted therapy, and we would just find the mutation. We had a bottle on the shelf that we would then treat the cancer with. And it hasn't proven to be quite so simple. And this particular network of how we treat, how cancer pathways works and within the cells, and it's complex. And this is just really to just show that it's complicated, right? The more we've learned, the less we really understand. And this is just to show that if you target one thing, maybe another pathway will open. So it's a bit like if you imagine a very busy city with all of their red, green lights, that actually, if they were all on green, you would have a lot of crashes. And if you take that as, you would then have a lot of cells just growing. But if they were all on red, you could stop it all. But obviously you would then have people left in one place. So I think just trying to simplify that, actually, it's just the more we learn, the less we really understand, and it just hasn't quite delivered on targeted therapy for all things. And this will become important later, and I will get back to that. So there was a time when we thought it was really this simple, that we had like maybe one type of brain tumor, and one was pink and one was blue, mostly in the context that actually they were by location, and we thought they were more or less the same, and we thought that we could treat them more or less the same. And this is still in my time as a registrar. And then the Germans did this really, so they looked at all the tumours they could gather from the area that was blue on the previous slide, and they worked out that actually they had lots of different types of tumours, and they were not what we thought they were. So, and also they found 4 new types of tumours. So the problem we now have is we have all these kind of new tests, new genetics, new understanding of what the molecular data is for these tumours, but we don't always understand how we manage that, and it has become even more complicated. And this is just some of the brain tumours that now is subdivided into smaller and smaller groups. And this is just trying to understand why we need you to do the molecular, and why we need you to sign up for some of the information so we can gather this. But what we have learned is that we've gotten really far with the molecular data over time, but what we haven't quite managed is to follow that up with the treatment. Because when you look back of these patients, they will have been treated differently and with different protocols, and therefore the groups get smaller and smaller, and it's really then very hard to learn how best to treat children. So it became more complex as we learned more. And this is some of the brain tumors, but it also goes for leukemias, where it used to be that you had acute lymphoblastic leukemia, acute myeloid leukemia, and there was few variations within that. But now we're looking at all these genes within the leukemias and trying to understand how we can use this information either to guide treatment or at least to prognosticate. So whole genome sequencing is now looking at this, and pretty much all leukemia children at least are having whole genome sequencing. So we are then moving to the targeted therapy and the personalized treatment, and it has worked for some, but not for so many tumor types. And therefore, actually what we have learned really from all of these previous tests over the last 20 years is really that we can prognosticate, and we can risk stratify the patients, and we can identify the bad and the good, and we can either escalate or de-escalate treatment. And therefore we can maybe improve outcome, and we can maybe reduce toxicity. And what we have also learned is that the cancer genome, and I know this is maybe too complex, but I'll come back to the basics. I was worried that my talk was backwards, but actually that this shows that the mutational landscape, or the mutations in childhood cancer, which are the ones here on the left, are kind of low, and it looks like a really bland landscape, whereas in adults there's a much higher mutational burden. And that explains a little bit about how we understand adult and childhood cancer. So childhood cancer is obviously not because children are smoking or because they've been exposed to all sorts of toxic drugs and too much sun over time, but really that's much more with the adults. But actually in childhood it's often just one mutation, and sometimes one mutation is all it takes to really mess things up. There is a small group here that you can maybe see in the middle here, that they have a really high mutational burden, and those are one of the very high risk cancer predisposition syndromes, and I will come back to that as well. So really, the landscape is bland, and often we just get this report that there is a few mutations, and what is really difficult to understand is what is the driver mutation. And these are concepts you may or may not be familiar with. Some of them might be passengers, and some of them are then germlines. And for this child with a TP53 mutation, a specific mutation for cancer predisposition and Li-Fraumeni syndrome, which I will come back to as well, there's an 80% variant allele frequency. And that means that it's seen in almost all of the cells. And this would suggest this child probably has a germline mutation. So this is what came out of the tumor. But when it is this common, we would then say, okay, we need to check this child's germline, which will be a blood test, or for the leukemias, it's often a skin biopsy, to check what is the genomics in this child. Yeah, so every building block in every cell. The NF1, a neurofibromatosis gene, also a likely oncogenic gene, and maybe he could have NF1. And then these other mutations here are of interest because maybe we can target them, and we know they're linked with certain brain tumors, so not in this context, but maybe this is something we can target it. But sometimes we just have a few mutations that we think are just passengers and actually are not targetable, and we don't have drugs for them. And then some of the children who has a specific cancer predisposition will have hundreds and hundreds of mutations. And here I've highlighted some of them in yellow because this was actually a target we could use for this child, and it allowed us to use a specific treatment. And therefore, this is why we are asking you, when you present with a child that has a new diagnosis, that I suggest this is what it might look like, yeah? So you've just had a child with a new diagnosis, and there's a lot of information, and there's a whole new vocabulary and lots to take on. So almost all tumors now have next generation sequencing. And we use this, other than just looking in the microscope, we use next generation sequencing for diagnosis often. We could potentially find a target that we can treat, which would make us all very happy, and there are a few. And then sometimes you need this information to see if you are eligible for a trial. Whole genome sequencing is something you should hopefully, if you have a child with cancer, you should all have been asked whether you would have whole genome sequencing for this child's tissue or tumor. And again, it might help with the diagnosis. Sometimes it can change the diagnosis. It can again maybe give treatment targets. And it will also, particularly the whole genome sequencing is very much also about the germline mutation and inheritance. So it takes a bit more from a consent process. But I appreciate that if you've just had a child with a diagnosis, started a journey you never anticipated in your life, and you're suddenly having to take all of these things on board, and I'm trying to say why these are important, and this is what you're going to be presented with. Then there's vivo banking and tumor banking, and I think those are incredibly important, and I'll hopefully demonstrate that for you. So when we talk about germline or constitutional, it means that these are the ones in pink, that the mutation or the changes in the DNA. So the germline is really what makes some of us have blue eyes and some of us have brown eyes, and those are the characteristics. And there will be other characteristics that there may be a risk of having early Alzheimer, or there may be other risks that is built into your whole genetics. And these will sit with, this is representative of the egg or the sperm. And then this will go, they will mix, it can come from either or both. It will go into the baby, be part of the whole baby, and eventually part of the whole adult. And can then these changes in the DNA will be passed on to the next generation. Whereas if you have a somatic mutation, which is the mutation we talk about in the tumor and the tumor only, it will not be found usually in the sperm or in the egg, but it will just happen. So this will be often during the fetal development, or it can happen anytime later, that maybe just one cell has a DNA change, and this may be that one DNA change that is going to bring on and cause the cancer and have the advantage of other cells that will then become a cancer cell, but be like one that everything originates from. And this can be anywhere in your body, depending on what the hit is and the timing that this has happened. There's nothing that we can do to prevent this. There's nothing we can do to understand this, but we are learning increasingly that actually this happens in really early fetal life. And then it sits maybe in one area, and it may be that you have a child where, you know, that sometimes children present at very, very young age, sometimes later in life, but it can still be from the same time. And as we discussed in adults, maybe it's kind of introduced with too much sunlight or something else. But importantly, this cancer mutation will not go into the offspring. So this will not be passed through generations, but will only be part of the tumor that hopefully can be cured and removed. And then how do you inherit it? So for some of the mutations that we have, it will be that just one parent is affected, but it will be autosomal dominant, which means, for example, that brown eyes is very much a dominant gene. So if you have a parent with brown eyes and blue eyes, the brown eyes almost always win. And therefore, but it sits maybe on just one gene, and therefore there is a 50% chance, because this woman has two genes, and she can pass on either the white or the blue gene, and therefore it would be about 50%. It doesn't always work like that. We have some families that have passed it to all of their children. Of course, there's some families that have passed it to none of their children. So it's random every time, yeah? And then if you have something that is recessive, it means that you have to be affected you have to inherit a gene from both of your parents, usually. And here, the risk to the baby is about 25%. So if you had 4 children, one of them would be carrier. Of course, again, statistic doesn't quite work like that, and there's no certainty either way. But this is how it is inherited and the pattern of inheritance. So just recap. So constitutional or germline passes through the germ cells and can be passed on to offspring. We sometimes have examples where there is a child has the mutation, and when you check the parents, neither of the parents carries that mutation. So we then say that it's a de novo mutation in the child. So it starts somewhere, yeah, and it doesn't always start with the parents, of course, because everything starts somewhere. We have found that sometimes we can find that mutation in the dad's sperm cells. We haven't checked whether we can find it in ovarian cells, because that is obviously much less accessible. So if we have a child that is with a cancer diagnosis that has a mutation and the parents don't carry, the new move within genetics is that we would still test the children, or we would offer testing of the other siblings, because it may still be relevant, but the chance or the risk would be much, much lower than if it is found in either of the parents. And then the somatic variations is the one that only happens in the tumor cells and will not be passed through offspring. So one of the best understood cancer predisposition syndromes are Li-Fraumeni syndrome, and it was first described back in 1969. And these 2 doctors here were looking at these families that seem to have this cluster of cancer, yeah, in their families, and they all had some kind of sarcoma, though they also described others. And here in highlighted in red is the tumor banking, because actually they did not have the technology or the know-how at that time to understand how they could get any closer to how this was inherited and how this runs in the family. But actually, so it wasn't until around 1990 that this was described, and the TP53 gene was identified as the cause for these cancers and being so frequent in the family. So this is called Li-Fraumeni syndrome, and is one of the reasons why children develop cancer. So I lost my mouse. So another cancer predisposition that is constitutional mismatch repair. So this is one of those that is autosomal recessive, whereas the Li-Fraumeni is dominant and you only need one gene from the parent. But this one, you tend to have to inherit a gene from each of your parents. And so often parents are related, but it is not a given that they have to be, because you can have some other reasons why 2 kind of random parents that gets together and they both carry a change in the same gene, and therefore the outcome will be the same. And this is a mutation in the cells that impacts on repair. So that means that every time a mistake happens in a cell, when a cell divides, a mistake happens and it does not get fixed. So this is like an exponential crisis of cell mutation that doesn't get repaired. And actually for the TP53, that is also kind of thought to be the guardian of the cells. So that is also a mutation that is supposed to, when you have a normal TP53 gene, you fix all the repairs. But when you have a faulty one, you do not fix the repairs, which is why you're much more likely to develop a cancer. And for the constitutional mismatch repair, it's a bit of a real mess, because they actually do not repair anything. They don't fix anything, but actually just keep making more and more mutations. So these children, we see, if the parents are both having only one gene, so they have something we call Lynch syndrome, and they present much later in life. Though we also do see some children with Lynch syndrome that develops cancer, but it is not thought to be much higher risk than the baseline of the population. But for the children who has both 2 faulty genes, they have a risk of developing cancer, 90% risk of developing cancer, and it is early cancer, and often around 7 years of age, as when they develop their first cancer. And they often have multiple cancers at the same time, or one following the other, following the other. So these patients are really, really high risk, and they often have adult type cancers. But what they have is, and this is where I showed you that the human genome is really bland, but there was that one spike of high-grade glioma that has a really high mutational burden. And this is in the context of mismatch repair deficiency. We see these really high mutational burdens. And this means that we have actually a option for curing them with immunotherapy. So many of you may have, if you have a child with a diagnosis, there will always be somebody who suggests, but what about immunotherapy? Because it's used in adults and it's maybe being discussed, but actually for children, it is rarely effective because they don't have enough mutations but in the context of this cancer predisposition, there is a really high mutational burden. So lots and lots of mutation, and immunotherapy works excellent. And we have cured children purely with immunotherapy without having to give them radiotherapy and or surgery. So it doesn't work for everyone, but it absolutely gives hope in something that is a little bit tricky. We have known for a long time that there are other syndromes. So here I've got the Li-Fraumeni syndrome. There's also neurofibromatosis, which particularly give low-grade gliomas, but also can cause, those children can also have ependymomas and high-grade glioma, and I apologize for the abbreviations. There's children with retinoblastoma who get tumors in their eyes at a very early age, but also can have pineal tumor, and longer term, they can have other cancers. And we know that when they have a mutation in the retinoblastoma gene, that if you then radiate them, they have increased risk of other cancers. So they don't repair again properly their genetics or their DNA. The mismatch repair we talked about. Rhabdoid tumor is a predisposition syndrome. There's Gorlin syndrome, where you often see medulloblastoma, a specific subtype. So that's medulloblastoma. And there's a disease called tuberous sclerosis, which affects young children, and they also get a kind of a brain tumor, but this often sits purely with the neurodevelopmental team, and actually these are rarely children that we treat within oncology because they can be treated with a targeted therapy that targeted this gene mutation. So it's behaving a little bit different at times. But there's other cancer predisposition syndromes, but where the risk is low, or the number of children with these syndromes are really low, and we are still needing to learn much more about this. There were these two papers that were published in 2015 and 2018, where two groups went back and they found as many tumors as they could, childhood cancers, and they had germline bloods for them. And then they looked at what are the mutations in the tumors, and more importantly, what were their germline mutations. And they found that in a whole kind of unselected group of patients with cancer or children with cancer, they found that just under 10% had a cancer predisposition syndrome. So in our population, we would expect about 10% of our patients having maybe inherited cause for having a cancer, and about 4 to 5% has a TP53 mutation, so Li-Fraumeni syndrome. The mismatch repair much, much rarer. So, and these number has kind of held. We haven't, newer publication papers doing something, people doing something similar haven't really moved these numbers. So we're still looking at just under 10%, and maybe 4 to 5% has Li-Fraumeni syndrome. But importantly, they found that only about 40% of these families had a family history of cancer. So though we always ask our families, this won't be enough to really decide whether you need to check the germline. So you should always be suspicious, yeah? And on this slightly busy here at the bottom, this just shows some of the different tumor types. Adrenocorticarcinoma is where they have 50% mutations, but some of the ALL also have specific subtypes. And here you can see TP53 was the most common one, and then NF1, and then some other mutations. So if we look at just in the UK, we have about, if we include the teenagers and young adults, we see about 4,000 children a year with a new diagnosis of cancer, which means that we would see about 420 with a cancer predisposition, and we would see about 200 patients with Li-Fraumeni syndrome. And we're definitely not finding those at the minute. But I think as we now offer whole genome sequencing for all new diagnoses, we will increasingly pick these up. And this is important because it often unravels. So you can see here, this child A was a child that came to under our care. She's about 3 years old, and she had a rhabdomyosarcoma. And because of her age and the tumor type, she was going to have genetic counseling and then testing for TP53. And more so, there was a family history that her mother actually had a cancer in childhood, and therefore that kind of raised the alertness even more. But as it turns out, her father, and I'll explain this, but the ones with just a dot, so the father was actually the carrier of the TP53, and this unraveled the whole family history that actually the father's siblings, both siblings, also carried the gene, but has not had a cancer diagnosis. So they are what we call unaffected carriers. And the grandfather did much later develop a prostate cancer, but that wouldn't be anything we would have particularly thought of related to the cancer predisposition. So I think it's really important that if there is a cancer predisposition gene and it's found in the families, that this isn't all doom and gloom, because actually I use this quite a lot in my clinic, that actually we really just don't know, and we are constantly learning, and we need to learn more. There's now a generation study that you may or may not have heard of, where actually they are doing whole genome sequence for neonates. But at the minute, we have not included the cancer predisposition syndromes because we thought it was too harsh to just have had a baby to be told they have a cancer predisposition. And because the service around the surveillance is still a little bit patchy, and there's only a few places around the UK that will offer this surveillance. So while we are fixing that, we haven't offered this yet, but that will probably change in a very short time, I imagine. What we also see coming into my cancer predisposition clinic is that now young mothers with breast cancers who have children, previously they would just have been tested for BRCA, and you may have heard of that because of Angelina Jolie, but actually, so the BRCA gene was thought to be inherited and leads to a risk of breast cancer, but we wouldn't test the children for BRCA because it's thought to be an adult disease. But because we've learned so much more about what we should test for, we no longer only test for BRCA in women with breast cancer, we also check for TP53. And this is where the story has unraveled for the children and actually is a real access point into my clinic. And we see lots of these families now. So I run this clinic where we do cancer surveillance in unaffected carriers. Yeah, so really important. These are the unaffected carriers, and these numbers are back from September, and I think I get about 3 to 4 new patients referred every month, and they are unaffected. Yeah, they've had predictive testing because there was a family history. Somebody was confirmed to carry. We would not offer surveillance just because there was a risk of a predisposition gene. We would have to have it confirmed, because otherwise we wouldn't offer the surveillance, both because of capacity, but also it would be unreasonable to put a child through that surveillance. And the surveillance that we offer is often a whole body MRI, either every year or every 6 months, depending on the predisposition, and also a head MRI at the same time. And then we do an abdominal ultrasound scan every 4 to 6 months, depending on the circumstances and the age of the child. And in this big group that comes into our clinic, we've had a few false positives. We've found 3 cancers, and one of them had multiple cancers and sadly died. But actually, this group is maybe a slightly different group with these children. So obviously, some of them are young, but I've had children in this surveillance clinic for the last 8 years, and they've had nothing wrong with them. And what we are hoping to learn over time is, who do we really need to see? Is it possible that some of these genetic mutations, not just the TP53, but some of the other mutations these children may have, there must be other things affecting whether they get a cancer or not, and particularly whether they get a cancer in childhood. We obviously have some children that has presented with a cancer first up, and then goes in and is found to have a cancer predisposition syndrome. And many of them now cross over to our surveillance, and we start surveillance early, even while they're on treatment for their first cancer, because we have found some that develops a second cancer on treatment, a different cancer. So we think that it's really important to do this extended anatomical surveillance so that we look at other sites other than just the one that may be the focus of the oncologist. And we also know that some of these children have an increased risk of developing second and third cancers. Yeah, but what we have found is that we find that they have progressive disease or metastatic disease sometimes, or new cancer. And importantly, it means that we can detect this early and make a real difference in the treatment and the outcome. So Li-Fraumeni syndrome has also, I spoke about the mismatch repair having a 90% risk of developing a cancer, but actually the males have about a 70% risk in Li-Fraumeni syndrome of a lifetime risk, and females about a 90%. And we are hoping this will change over time, because the early surveillance will pick up things early. Of course, that is still a cancer. We're also now offering bilateral mastectomy to the women, and much more intense screening and surveillance also for the adults. But we know or the data is that about 41% gets a cancer before they're 18, 22 before they're 5, and 4% in the first year of life. So we would offer surveillance as soon as possible, and even offer them with the MRI, the sedation or general anesthetic, though some families choose to wait until the child can have the scans awake. We would still see them and do a clinical examination and the ultrasound scan. So we still have much to learn, and we really don't understand this genotype, phenotype, so specific mutations and what cancer they get, what age they get a cancer, what type and where. So this we don't understand at all, and only by, I think, running this surveillance clinic in a few centres will we have enough patients to really learn. If every oncologist has about 10 children in their clinic with a cancer predisposition syndrome, we know we're not good enough to pull data together, and we will then really struggle, yeah? And this just fanciful drawing here, really just these two twin girls are in my clinic and has been for some time and are very well, but lots of these families obviously come with quite a devastating family history, which makes it difficult for families, but are all hopeful that we'll find an early diagnosis. And if we find the cancer predisposition gene and it is identified and tested for, sometimes it means that the treatment needs to be altered or changed. We need to think about other malignancy and the higher risk of second tumours, and then of course the risk for family members. It's really tough if you just had a diagnosis of a child with a cancer and then you find out that you carry a gene yourself, and suddenly your risk of cancer is much higher, and then maybe the risk to the other children, and it's really a very, very challenging situation. But this is just to mention, and this is what makes my day, right, in the clinic, and why I'm now seeing over 130 children coming through my clinic that I see every 4 to 6 months, is that actually we had this boy who had a delayed diagnosis and did not survive his adrenal cortical carcinoma, but his sister on surveillance had this small tumor detected on surveillance. And actually I put in the growth chart because actually this should have told me the diagnosis even before she had the MRI scan, because this is very, very typical, that this excessive growth over a shorter period of time. But actually she's had an operation and is now perfectly fine and keeps coming to my clinic. And unless he gets another cancer, she is cured. And we know that about at least 50 to 60% do not get a second cancer, yeah? So they still count within their 90% lifetime risk, but hopefully she's now done and won't have any more, yeah? So I think this is my last slide, I think. So this is really just that children are clearly different than adults, and the cause of cancer is different. Cancer predisposition is in about 10%, and therefore I would recommend that if you can get your head around it, maybe have the whole genome sequencing. Some families do not want to know, and that's also okay. I think all of the families, and we've surveyed this through the clinic, find that actually if they know, and they can have they won't know if they don't want to know if they can't have the surveillance, but if they can access the surveillance, they will want to know, because then there's hope, and then there's a promise of a possible early diagnosis. It's not a sure thing. Sometimes, you know, a cancer develops 11 months after they've had their first screening, and therefore we've missed it because we only scan them every 12 months, but we should have picked it up maybe on our questioning and maybe better history taking, and we learn something every day, yeah? So I think cancer predisposition is many things, but it really is that you have an inherited cause that puts you at higher risk of developing a cancer, but not a certain risk of developing cancer. And that's really, really important. And we give lots of red flag symptoms about what people need to look out for. And actually, they're no different than what the rest of us needs to look out for, and not make excuses. If something hurts for a prolonged period of time, maybe we should have it checked and not just ignore it and make excuses. It can often pass, and I think that this is what makes it really difficult for families. I've had parents being completely panicked about what this might impact for the other children and for themselves, and surely it can be inherited. But in 90% of the cases, it won't be inherited. And for those, we don't really fully understand what causes that cancer, what causes that early mutation. But really important, there's nothing that any parent can do to prevent this. If you do carry the TP53 mutation and you want a baby, you can have antenatal testing so that you can have IVF and therefore avoid having more children with the same gene mutation if you so wish. So thank you for your time. I think I'm just about on time. So it's a bit of a whistle-stop tour and maybe backwards, but hopefully the beginning kind of made sense once you understood where we were going with this and the reasoning for why we're doing things and what we're hoping to achieve. But I'm happy to take any questions.
Firstly, thank you.
Stop sharing.
Yes, please. Then we can all look at your face. No, that was really interesting. I mean, I remember hearing you talk about your work in the clinic, and it's fascinating and obviously quite a tough topic. So thank you very much for sharing it again today. So we already have a couple of questions. So the first one, in your carrier surveillance clinics, the ones that you drew out on the slide, do you only accept children or siblings, or do you see and collect data from parents as well? Are there any interesting trends being seen in carrier parents, if you have that data, since they're older than the child's siblings?
What is there any changes in the adults?
So I think it's asking whether you also do surveillance for the parents too, or collect data about them, and then has this data told you anything?
Yeah. So we don't so much. We do always take a family history, and we are collecting that, and we are looking to publish, but we're actually looking to just publish about the children. It will obviously all be anonymized, but we do collect it. And I think what we do learn is that lots of parents, some of them have a traumatic history, either they've lost a sibling or they lost a relative, but actually some of them are completely unaffected and only knows because it's unraveled from one place in their family. So we do collect that, but usually lots of this sits within genetics, and there are studies, and what we do know is that the surveillance are beneficial for outcome, is certainly what the Toronto group has demonstrated, and whole body MRI and head MRIs have now been agreed to be funded by NHS England, and the cancer genetic teams around the UK are currently working out where that surveillance should sit, because it won't be every hospital in the UK, because they won't have the expertise or the possibility to do whole body MRIs and know how to read them, but it is coming and should therefore be available to everyone if they haven't already got that. So it's about making contact back to their cancer genetic teams. And then there are some studies. There's a study called the Millie study. So if anybody's interested, they can look at the tp53.co.uk website. It's not yet open in too many centres in the UK, but it's coming, which is also kind of a surveillance, but also an intention to see if metformin can prevent cancer development. And for parents and children can enroll on that when they're 16.
Thank you. Oh, my mic is on. Perfect. Okay, so next question is, can the TP53 gene be turned on and off?
No, not at the minute, no. So we can't do that. I don't know, there's quite a lot of interesting technologies coming through with gene editing, but not yet for TP53. No.
I'm going to ask one of my questions, if that's all right. I've been scribbling them away while you've been talking. So, have you any idea why some of the carriers are unaffected? Is it just a matter of luck, or do you think there's like some underlying genetics that's protecting them at the same time that their other genetics are making it worse?
I think it's likely there's some other cause for sure. I don't think it's pure luck. I think we just don't understand. So we are running a study with the Sanger Institute, which they have got funding for, which is excellent. So where we are collecting blood tests from like as many family members as we can, but certainly the parents and the child affected and the siblings, if they are willing, or whether they are affected or not. And we are trying to understand what other mutations we can find and try to kind of almost generate like a heat map, if you can imagine that, to just see whether there's other mutation. And maybe we need quite a lot of cases, but to see if there's a trend, because this would help me understand whether we can identify the children who does not need surveillance in childhood, and maybe they just need surveillance when they're adults. So it might be that we can identify a group that is lower risk. At the minute, it's definite. There's lots of different TP53 mutations, but that is definitely not what defines this purely, because you can see even within families there's a variation. So we are needing to learn much more, and that is really why kind of tumor banking, signing up for studies, in order to help these families and learn much more, the work needs to be done. So we are trying to do that, and we'll hopefully understand, but it will take some time.
Thank you. Okay, we've had a flurry of questions. So first one is, this person can't remember if their son did have genome sequencing when they were at GOSH 7 years ago. Is there a way they can find out?
Yeah, they wouldn't have 7 years ago because it wouldn't have been available, so they definitely wouldn't. If they're still coming for long-term follow-up and coming to the long-term follow-up clinic, and if there is some unanswered questions, if there is tissue, it is still possible to do that, but there has to be frozen tissues, which we are now doing routinely for all, but we haven't necessarily always done. But it's definitely something that can be discussed, and we are thinking about whether we need to try to offer this in the long-term follow-up clinic, because in order to unravel is maybe not the best word, but in order to make sure that we do not miss something, if you know, and therefore people can't access the surveillance that is available if there is an increased risk. So I guess it's a personal choice about whether you want to know.
Okay. Next question is, this person lost their son to acute myeloid leukemia and he also had bone cancer. They have other children, but they've not received any tests for cancer. Is this something that they should be looking into?
I think having 2 cancers, I would say definitely yes, that is unusual. Yeah, there are some treatments that can cause a second cancer, I guess, but even that would make me a little bit suspicious. So the challenge will be how you access that, but it would be having a conversation with the treatment team and then maybe just get a referral to genetics, because genetics would then offer the testing for the parents. And then you can discuss whether you wanted the other children tested, but we would always start with the parents, though, as I explained, that there is maybe a 3 to 5% risk, even if the parents is negative, but it's a much, much lower risk.
Okay, so on a similar vein, somebody's asked whether they would be able to use the late effects clinic or be referred through the late effects clinic for testing.
Yeah, I think they could be referred to the genetics. They would have to have kind of a, you know, more than just, I guess, an interest, but I think it is possible. I think you could reason it, discuss it, and the geneticist could have that as a bit of a flurry. Or what we should do is we should try to open it up as a research project to just collect the samples and the data. That doesn't mean the family would get the results, but it's just that it's finding a way where this is funded. But I would think it would be possible to get a genetic referral, and the cancer genetic group as such has significantly grown over the last 10 years. So it's become something where it's previously was hardly anything. I mean, I inherited the genetic clinic about 10 years ago, and there was 2 patients every other month. And now I run the clinic 3 times a month, and I have 12 patients every week. So it's a changed environment, yeah.
Yeah, definitely. Okay, are you okay for a few more questions?
Yeah, I'm good.
Okay, I think I'll do this one because it's sat in front of me. So somebody would like to know, can TP53 be controlled by nutrition?
No. I know that for cancer, often parents ask us about kind of a ketogenic diet, which is hideous, practically impossible, and makes somebody feel really terrible. But I don't think we've got enough evidence around that. But you can't. I think for everybody, for all of us, you know, a healthy lifestyle, trying to avoid too much processed food, and exercise is definitely all things that will help, because we know that even though cancer is very much a genetic disease in a way, there's no doubt that your immune system is involved in that whole process about whether the immune system recognizes the cancer or not. So I think all of those things are still important and shouldn't be minimized. And it also empowers us to do something that is good for ourselves, right? There are some things we can still control.
Yeah. Okay, so the next question is, do you think there's a benefit to all these children being seen in just a few centres rather than for scans to happen in lots of different hospitals and then be sent into the main hub, I guess?
So I think so. So we always discuss whether this should sit in oncology or whether this should sit in general pediatrics for the children. For the adults, it sits with genetics, but for the children. But I think that what the benefit of having it within an oncology setting is that I run the clinic away from my oncology clinic, so the children do not see any oncology kids when they are in. If they're unaffected, they do not need to be faced with what could come. But I think that what we have is we have the expertise. So I have a CNS that is linked with the clinic, and she can answer questions. So the family has her phone number, and they can ring and call her. And if they have a worry, she has a really good sense of filtering the questions. And if she's worried, she'll call me and she says, what do we do? Do we get them seen locally if it's far away, or do we just get them to come to us earlier? So I think that's important. And the other thing is that on lots of the scans, you often, particularly on the first scan, you find things that are probably normal, but it's just, you know, we're not all put together perfect. And therefore, we find things, we can then immediately take that to our MDT, and therefore we can easily clarify whether this is something we need to just watch, or whether this is something that we can do a repeat scan, or whether we need more imaging done. So I think that expertise is really important. And I think you only get that if you have a bigger centres. What I suggest the question is, could we scan elsewhere so not everybody has to travel to Great Ormond Street Hospital? So we have children coming down from Newcastle and Leeds. There is now a centre in Manchester will do the surveillance, and Birmingham will do the surveillance, as will Oxford. But families from Newcastle and Edinburgh are still travelling down, but often they just travel once a year. So they do the whole body MRI. I try to see them when they're on site and do the examination and check on them. And then the ultrasound scan is often arranged locally, and we can have a virtual consultation if they've been seen and had their MRI scans and ultrasound scan with us once a year. So I think most families choose that it is okay to come to London once a year. They make a bit of a trip out of it, and then we can manage 1 or 2 nights accommodation within the hospital, depending on kind of timing around the scans. So so I think that's kind of agreeable. And then if there is a problem on the scan, we reach out to the local teams and get them to do some of the follow-up if we can, so that they don't have to keep coming to London. But I think we might need 5 or 6 centres across the UK, but I don't think we need 20 or 21 centres, which is how many oncology centres there are.
Sounds sensible, especially with the increase in technology since COVID for virtual things.
Yeah.
Okay, I have 2 more questions. So how is a sample taken for, it says NGS, I'm not sure if that's whole genome sequencing or not. Do you take their blood?
So we try to do bloods just because we've streamlined it, and we started with bloods. What we've learned more recently is that we can do a buccal swab. So you have to do 3 swabs, and you have to just kind of do 10 strokes on either side on the inside of your cheek. It's nothing like a COVID test. It does not go up your nose or down the back of your throat. So it's not quite as hideous as that. And actually, we often get a good DNA yield for that. So currently, we are asking, if willing, we're asking for a blood test for the first sample. But it is really true that the children who come to my surveillance clinic, they do not want to come and have a blood test. And some of them come all cramped up and holding their arms really tight until I reassure them that they're not having any more blood tests. Because some of the surveillance is some places will do blood tests and also to do more research. But actually, I think that's unreasonable for children that are well. So if it's an absolute no to the blood test, we try a buccal swab now, because we've gotten much better at that. But that is more recent.
Okay, well, I have a related question. So somebody would like to know, their child had a private cheek swab taken which indicated a TP53 mutation, but their whole genome sequencing blood test didn't indicate that. So can one be incorrect?
I think it should probably be checked. It would probably be worth running that again. So either running just the TP53 as a blood test. It's difficult to know which one is wrong and which one is right. Yeah, I mean, we do take the whole genome sequencing, but I guess sometimes that can be a misread. Sometimes things are not always perfect, right? So I wouldn't take that as an absolute, depending on kind of the background, and could maybe be retested again.
Okay. No, yeah. And I guess the thing to say to everyone is talk to your care teams if you're worried is always the go-to, because a lot of these webinars, I often have researchers that aren't practicing clinicians like you are, so obviously
I will yeah, and we take to the clinic, we take referrals from the GP. We don't quite take self-referrals, but almost. But the GP or the geneticist or anybody can refer to the clinic, and the minute we see anybody who is willing to come.